the dysfunction that we have in the antinociceptive system in patients suffering from medication overuse headache. And it seems this is connected to the, in parallel to the anxiety level also of the patient, according to the recent report. And we know also that there is also a genetic susceptibility to this, to develop a medication overuse headache. So these are conditions that we should consider in our patients, which are the acute migraine medication that can be found as evolution in a patient suffering from episodic migraine to a chronic migraine. Acetaminophen, according to this report, is considered to be a reference, but as you may see, barbiturate are at top level with the odds ratio, opioids, triptans, and at lower level, it's non-steroidal drugs. According to the report, it seems that this last category seems to be protective if you have a low level of non-steroidal analgesic drug protection against medication overuse headache. But as you may see from the lower part of this slide, what is important that episodic migraine sufferers can develop progressively chronic migraine with a rate of 2.5% per year. That is very important to be considered. And which are the most frequently used drugs in according to some retrospective studies? We have analgesics association, analgesics alone, triptans, opioids, and ERCO derivatives that are getting lower and lower. This was a compound that was used mostly in the past. Now the triptans are getting more and more importance. There is a risk to develop medication overuse headache. The possibility to develop a medication overuse headache in a patient suffering from episodic migraine in 1 year is there is a consumption, monthly consumption of medication, more than 5 days with the butalbital, more than 8 days with opioids, more 10 days with triptans, and 10 days of non-steroidal analgesic drugs. So the patients may be at risk of developing, even with the episodic migraine, or developing a medication overuse headache. There are also some other risk factors important that some patients, if they use regular tranquilizer, if they use some other drugs, caffeine, if they're smokers, if they have a psychological problem, and if they have some other chronic musculoskeletal disease, like, for example, fibromyalgia. The triptans probably now are the most common cause of medication overuse headache. Probably it's the same in Bulgaria. That's what we see now in Italy. We may say that the triptans work very well, do it better. In fact, in the mean time to develop a medication overuse headaches is 1.7 years. For ergotamine, it's a little bit longer, and as longer and longer for simple analgesics that reach up to 4.8 years to develop medication overuse headache. How are we going to treat patients? First and foremost, it's important the diagnosis, because sometimes the diagnosis is missed. Then we have to make a detoxification, and it is important the follow-up to avoid a recurrence of medication overuse headache. The diagnosis is very important. You have to collect a careful clinical history and headache history. Patients come to your office with a lot of experience on a prophylactic drug for a short time, prophylactic drug at lower dosage than is expected, and patients that they have never done a detoxification. These are the typical patients that are coming. So please use a headache diary. So before detoxification, during detoxification, and later on to follow up the patients and the consumption of medication. According to Christina, probably the best medication overuse headache treatment is the abrupt drug discontinuation. And this is what usually we do in our headache center. The target is the suspension of a drug. We have this kind of protocol, control the symptoms during the withdrawal syndrome and phase that you may have in your hospital, and prevent the relapse of medication overuse headache. Patients feel very bad when you stop triptans, when you stop analgesic, combination, opioids, and during the stay in the hospital, they have headache, they may have nausea and vomiting, hypotension or hypertension, tachycardia. They may have trouble in sleeping. They may be anxious. They have sometimes seizures if you stop right away the use, for example, of barbiturates. So it's important to evaluate each type of medication that is abused and adjust your treatment when the patient is in the hospital. These symptoms during the withdrawal from symptomatic drugs may last from 2 days to 10 days. That is why we keep the patients from 7 to 9, 10 days in the hospital. These symptoms, this withdrawal symptomatology is shorter when patients are using triptans, and it is longer if they use ergotamine or analgesics. Sometimes they have tension type headache or they have a real bad migraine attacks, especially if they're abusing from triptans. Patients with ergot or triptans may have both of them a prolonged, sometimes severe migraine attacks. Sometimes the migraine attacks may last 2, 3, 4 days. And in this case, we should have a more aggressive approach to the headache during the hospitalization. How can we treat these poor patients when they are suffering and they have to be out of this very bad symptomatology? There is no guideline at the present time. Tomorrow we will see something that is a consensus on guideline, but is a guideline for behavior. It's not a guideline for pharmacological treatment. There are general rules that you have to consider for our patients. The advice, you have to be available. I always see patients at least 2 times a day. You have to have a 24-hour nurse support, the psychologist, and you have to see these patients more and more times along the day. This is why they need an hospital care. It's very difficult in my experience to get out of this situation when you try to do as the outpatients this withdrawal. There is, you may approach the patients with 2 different conditions. One is the abrupt, one is the tapered withdrawal from symptomatic drugs. I use for opioids, barbiturates, and benzodiazepine, if they are in addition to the symptomatic drugs, a slowly tapered withdrawal. But for the other drugs, I get rid of medications right away. And it is important to monitor the general condition of the patients. Blood pressure, fluid replacement, you have to sedate sometimes the patients because he's anxious, you have to counteract nausea, and so on. And sometimes you may need some other rescue medication, because if the abuse of paracetamol, in case you may use indomethacin, or in the other way around. And even it's the same if they are abusing of triptans. The rescue medication, so it's very important during this period. Sometimes we use ice pack, but that may not be enough. And there is a bridge treatment, what is called, and you may use hydroxychloroquine, valproic acid. It depends on what is available in that hospital. Sometimes steroids. If the patient is suffering very bad, I put them in with steroid every day. And you may also have some other support for such patients. Naproxen, in my experience, is good when they have headache after withdrawal. Sometimes you may use tizanidine, and if they have an overuse opiates or barbiturates, we use clonidine patch, 2.5 milligram patch. Then there is the possibility to start with a prophylactic therapy during this phase of withdrawal. There are different contributions. Some of these contributions are also recent. We had one comparison between celecoxib and prednisone that showed no major difference between the two during this treatment. Sometimes you may use oral prednisolone, but this was not found different from placebo. And sometimes you may use parenteral methylprednisolone or paracetamol. In some cases, I use methylprednisolone. Sometimes I may also use paracetamol, but according to controlled study, there was no, these were not superior to placebo. So, what shall we do? There are no definite guidelines, what we said. We have a day hospital regime for treatment, and in my opinion, is not functioning as it is the hospital regime, because in day hospital, usually patients leave the hospital at 4 or 5 o'clock in the afternoon, and the problem is during the night. If the pain comes strong during the night, patients will take something, and then the situation gets worse and worse again. Detoxification is can be done, as we said, as outpatients regime or inpatients regime. The outpatients regime is for patients not using barbiturates, benzodiazepine or opiates, if they are very motivated, and if they don't have other side effect from the medication overuse, ergotism, problem with the sleep, or renal insufficiency. In this case, and also patients that are suffering from depression and anxiety should not be detoxificated at home or in a day hospital regime. The hospital detoxification has some general rules that we may also see tomorrow, and some pharmacological approach, but in most of the cases it has to be a multidisciplinary approach. We have a pharmacological treatment that lasts for 7-10 days. The use of headache diary, the psychological assessment is very important. You have to do an educational program during the days that they're staying in the hospital, and a follow-up program later on. Probably the best treatment is the discontinuation of the overuse medication. This is the best thing to do. But according to some contribution, the start of a preventive medication is even much better. There is no agreement at the present time how we should discontinue the medication and when we should start the preventive treatment. This is something that belongs to the personal experience. I'm going to show you which is my experience. In my experience, according to this situation we spoke before, I prefer to have an abrupt suspension of the overused drug. Then it's important to provide a fluid replacement, detoxification with some compounds, control the pain that you may have, as we said, control the nausea, and some other withdrawal symptoms that may be together. And in case you have patients abusing of opioids, it may be important to use a clonidine patch, and in this case, it's easier to overcome the situation. And with barbiturates, we have to use oral barbiturates that you can slowly taper off from that situation. Otherwise, you may even have also some seizures. As you may see here, the pharmacological treatment is based mostly on the hydration. We have some detoxification with some compounds, and we have to control anxiety, nausea, and you have to provide the rescue medication according to the drug that is overused. In case of opioids, the clonidine patch, and with the barbiturates, the butalbital or phenobarbital, that can slowly be tapered to zero. Then you have to start the preventive treatment, and this has something to do with the previous experience of the patients, with the other comorbidity of the patient that you have, and you have to start the educational rehabilitation program during the stay. It's important to use the headache diary. We now use most of the case this head-up diary, where you collect all the information for the patients, the duration of attack, the number of drugs that are assumed by the patient. It's important also the psychological assessment. During the stay, they have to make a psychological assessment and possibly 2 or 3 sections of a psychotherapy, general psychotherapy, how to approach the pain and the use of analgesics. You have to do an educational program. There are some concepts that the patient should learn. Headache is a chronic disease, but you can get better, but there is no real cure. You have to avoid some trigger factor that you can identify, so the lifestyle is important. Not all the headaches are the same, not all the pills are the same, and you don't only have a headache, but you may have also some other comorbidity. This is the headache school that I'm running with the patients. It's 7 days, 7 lectures for patients to improve their lifestyle and to know about medication overuse headache. When the patient goes home, it's important that the neurologist will follow the patients every 2 months, every 6 months. At a different stage, you have to have contact with the email and education provided to the family. And that is very important to avoid the relapse of medication overuse headache. This is an approach that was published some years ago, and I don't agree completely on the approach, because I'm used to see patients. I'm not used to just write papers in the library. And so I think that, of course, you have to withdraw from medication. Some of the antiemetics that you use cannot be so easy to find, and they are not easy to use in the hospital. And acetaminophen oral compounds is useless, and so there are some things that I agree, but some other things I may not agree on that. After the 7 days, you have what you have to do at home. But before you go home, you have to start the preventive treatment in these patients. Here you see different compounds that can be used. I use, in most of the cases, for the beta blockers, timolol, that is not mentioned here. The dosage of propranolol here is probably too high. And the same flunarizine, I use no more than 5 milligrams. Here it is 10. Amitriptyline, in most of the cases, 20, 40 milligrams, it's enough. You should not go on. And candesartan, in my opinion, is not effective. The protocol when the patient goes home is to use the headache diary, allow the patients not more than 2 symptomatic per week, and so on. I just want to spend a few words about the opioids, because they are coming more and more in the routine practice, and according to the literature and in my experience, tramadol has not much efficacy in migraine, not indicated for tension type headache, and there are some risk when you use it in acute in the first aid department. And there are more and more patients that are coming to your office using codeine alone, or in most of the cases in association with paracetamol or other drugs. So it's important because codeine is an opiate and is not so easy to stop it. There is some numbers that show that the patients, if they are properly treated from chronic migraine, can go back to episodic migraine. And this is something that is very important in our experience. So this means that we are approaching in the best way our patients. But it is true also in the other way around, that some patients, they may have a relapse to medication overuse headache. In most of the cases is within 6 months, up to 40% in 1 year, and less in the following years, probably because they adapt to a new lifestyle that prevent to use more and more medication in our patients. So we have to treat all the risk factors that we have been speaking about: depression, smoking, alcohol use, blood pressure, and so on. Thank you so much for your attention. Probably I've been too long, but it was what I had to say at least.
Thank you, Fabio. You were not long. It was very interesting. I have one question. What do you think, and do you have any experience with treatment with the new monoclonal antibodies for this headache? I know that it's not indicated, but I suppose that in the near future it will be indicated for this.
Well, in my experience, I've been using the last 1.5 years the monoclonal antibodies, and I've seen patients who have been used these antibodies in other centers. In my opinion, the best result is when you have to start the antibody, you have first to withdraw the patient from symptomatic drugs. So if he is taking or she is taking 20 triptans per month, and you put the patient on monoclonal antibody, it may go better, but it may be no change so far. My experience is a limited number of patients. I've seen patients treated with monoclonal antibody in other headache centers in Rome, in Milan, and close to Bologna, that they were put on monoclonal antibody without any withdrawal from analgesics. And this was a failure. It's a failure for the doctor, it's a failure for the patient, it's a failure for the national health system, because this is a costly therapy. So in my opinion, I took this patient, I withdraw them from medication and send them back to the neurologist so they could go again on the program with the monoclonal antibody. And up to now, all the patients that have been treated and detoxified in this way, they have a good result from monoclonal antibody.
Thank you. Thank you. And probably you have more experience with patients with chronic migraine with monoclonal antibodies. But usually it's very difficult, it's very difficult to separate medication overuse headache from chronic migraine.
Yes, we have been treating patients with one monoclonal antibody, I don't want to say which one, and this we obtained a good result. The patients that I selected are patients that all of them, they were chronic migraine with medication overuse headache, and in all these cases, I withdraw them from medication. After the detoxification, I started with the monoclonal antibody, and they are in good shape. They say that the frequency is low, of headache. Sometimes they have headache and they don't even need a symptomatic drug. And so, I mean, this has been a change in the life for these patients. But for my personal decision, I included in this treatment only patient detoxified.
Yes, I understand. Thank you very much. I think this is very important. This is absolutely very important. Okay, there are no more questions. So thank you very much and see you tomorrow morning.
See you tomorrow. Very early in the morning, okay?
Yes.
Very good.
No, for you it's early, for me it's okay. We are okay. 1 hour.
Sorry not to join you at the dinner, but okay. That will be for next year, of course.
Yes, I hope. Okay. Yes. Have a nice evening.
Okay, then we'll see you tomorrow around.
Yes.
Okay?
Bye. Bye. Thank you very much.
Bye. Thank you.